All right. Well, thank you everyone for joining. We're excited to have you here tonight as we take you through this important step in navigating your knee pain. You may have a new injury. You may have been dealing with pain and stiffness for some time or simply not moving around the way you want to. Whatever it is, Summit Health Orthopedics is here to help. So our goal over the next 45 minutes is just to share some ways you can improve your knee health. If you have a question at any time during our webinar, you can let us know by clicking the little Q&A button that you see in the bottom left corner of your screen, and we're going to address some questions later on. So just a little word about Summit Health. We are one of the tri-state area's leading providers of primary and multi-specialty care. We have specialists in over 80 areas, and we see patients in more than 340 locations. Our partner, CityMD, is our urgent care provider and one of the leading providers of urgent care in the Northeast. The good thing about Summit Health is that we are a connected team with CityMD. So we have many primary care doctors who can lead the healthcare teams. We have specialists in every single field that can address any specific needs. And we also have the urgent care solutions when things are just can't wait. So wanted to go over our discussion today. My name is Dr. Solomon. I'm here with Dr. Benke. A little bit about myself. I'm an orthopedic sports medicine surgeon. So what that means is that my focus is on knee, shoulder, and hip issues. I've done specialized training in arthroscopic surgery and minimally invasive techniques. I've worked with sports teams at every level, high school, college, pro athletes. Right now, I am centered in the Florham Park location for Summit Health. Currently, I live in Summit, New Jersey. I've got my wife, 2 little kids, and a cute little dog named Winky. Dr. Benke, if you could tell us a little bit about yourself.
Yeah, thanks, David. So like Dr. Solomon, I'm a fellowship-trained orthopedic surgeon, sports medicine specialist, focusing mainly on arthroscopic surgery of the shoulder and the knee. I, like Dr. Solomon, grew up in New Jersey. Then I traveled around the country for all my schooling, New Orleans for college, back to New York City at NYU for med school, then to DC, then to California for fellowship, and then finally back to New Jersey where I live with my wife and 3 not so little kids anymore.
All right, so we are going to start with a poll today. So how would you rate your understanding of knee injuries and ailments? I have no knowledge. I have some basic understanding, but want to learn more. Or I have a solid understanding, but I am tuning in to learn more about Summit Health and connect with a physician. All right, here are our results. So the vast majority, some basic understanding, but want to learn more. I think that's great. That's right where we want people to be because, we're going to talk today about some basic stuff, but also hopefully give some extra information that can add to what you guys already know. So here's the topic for today's discussion. We're going to talk about some acute injuries and also some chronic ailments. So we're going to start talking about ACL rupture, which is one of the most common injuries for athletes, meniscus tearing, which can occur either as an acute injury or something over time. And then we'll get into cartilage damage and finish on the topic of osteoarthritis. So what is the anterior cruciate ligament? I'm sure everyone's heard of ACL tears in athletes, but what does this actually do? So this is the strongest ligament in the knee. It connects the femur, which is the top bone in the knee, to the bottom bone, the tibia. And this is very important for the stability of the knee. So it controls like translation forward and backward, and it also controls rotation of the knee. So this is important for cutting, pivoting, jumping, all these things that athletes need to do to perform. What are some causes? So this can be either a contact or a non-contact injury to the knee. We see this very often with sports such as skiing, football, soccer, amongst many others. But I also see this just with everyday accidents. I have patients who just took the wrong step on the stairs. In the winter, they may have slipped on the ice. So this can really happen to anyone. It's often associated with feeling or hearing a pop and this is followed by rapid swelling of the knee, usually limited range of motion and difficulty weight bearing. So in general, when someone has these kind of injuries, I often hear patients just tell me like, I know I did something, so this is not usually a very subtle injury. One important statistic, ACL tears impact women 3 times more than men. So I always try and keep that in mind, because when I have a female patient who presents with some of these symptoms, I always have to be on extra guard and extra suspicious that something like this may have occurred. So treatment for ACL tear, this really ranges from non-operative management to surgery, and it really depends on the patient and what your goals are. So for non-operative management, we typically do physical therapy. You may have to modify some of your activities, and we can brace the knee for stability. However, for many patients who engage in sports or any sort of activities requiring side-to-side mobility, the ACL is a really important structure for these activities. So anyone who does, skiing or pickleball, tennis, these sports, I usually recommend getting the ACL fixed. Any patient who's experiencing instability, buckling of the knee, feeling like it's giving out, that's another person who's a good candidate for surgery to get a new ACL. We have no specific age cutoff. However, patients who have advanced arthritis usually do not benefit from a reconstruction. So what does ACL surgery look like? This is typically a reconstruction rather than a repair. The ACL does not typically heal itself, so that's why we have to replace it with something new. Now, a hot topic in orthopedics these days is what kind of graft do we use? Dr. Benke, do you have any preference in your practice what kind of grafts you're using these days?
Yeah, definitely. So there are 3 main types of autografts, meaning tissue from your own body that you can use to reconstruct the ACL. They are the patellar tendon, the hamstring tendons, or the quadriceps tendon. And all of those different grafts, some surgeons like for different reasons, or they all have their pros and their cons. My preferred graft is the quadriceps tendon. I transitioned to that probably about 7 years ago or so, and have found a lot more upside, meaning less failure rates, and less downside, meaning there's not as much pain in the area as something like a patellar tendon. But all 3 of those are acceptable grafts.
Totally agree. In my practice, I would say the quadriceps tendon is the #1 graft. I think it's very strong. It's very cosmetic. But again, there's pros and cons to each graft. So that is always a kind of a personal choice between you and the surgeon, depending on what we're looking for. This surgery is mostly arthroscopically, so it's a minimally invasive surgery, and it's performed outpatient. So you come in, you go home the same day. Recovery, just a basic overview. Typically, you're in a brace for 6 weeks after surgery. You can start jogging around 3 months. At 5 months, it's more cutting, pivoting, explosive maneuvers. And then we hope to get our athletes back to full sports around 9 months. So I'm going to hand it off to Dr. Benke. He's going to give us some information on meniscus tears.
Great. Thanks a lot, Dr. Solomon. So #1, what is the meniscus and what does it function? So the meniscus is a shock absorber inside of the knee. Its job is to protect the cartilage and to prevent arthritis. So cartilage is what lines the ends of the bone. When that wears out and wears thin, that's what arthritis is. So the menisci are, again, the shock absorbers that help distribute the forces and help protect the cartilage inside the knee and prevent arthritis. They also play a role in stability of the knee. We have 2 menisci in each knee. There's a medial meniscus that's on the inside of the knee and a lateral meniscus on the outside. And so how do they tear? So interestingly, I would say most common, maybe 50% of my patients with meniscus tears can't recall one specific injury. They present with pain, not sure how it happened. And I think probably as we get older, the meniscus tissue is not as good, and it can tear with even very subtle motions. It can also happen more traumatically, a big sporting event, twisting injury, or a subtle, sort of more subtle misstep that patients do remember. So the symptoms and diagnosis. So patients will often present with swelling, water on the knee. The knee feels tight, especially when they try to bend it. Tenderness along the joint line, either medial or lateral, depending where the tear is. A lot of times patients will report pain at night, especially when they lay on their side and the knees come together. That can cause pain with a meniscus tear. Oftentimes patients will also describe what we call mechanical symptoms, so locking, catching, giving way, or a sense of instability. There are many types of meniscus tears, which is why there are many types of symptoms and presentations. You can see these little diagrams are different types of tears based on the pattern. A longitudinal tear on the outside part, radial tear, sort of like the spoke of a bicycle, a bucket handle tear where it tears in a big piece, flips and gets stuck. That can often be a more dramatic presentation where the knee can be locked, you can't bend it, or a combination of all these tear patterns, what we call complex tears. The way they're diagnosed is an MRI. That would be the gold standard to diagnose meniscus tears. All right, so occasionally these tears can be treated without surgery, and I always start by telling my patients when they present with knee pain, this might be a meniscus tear, but not all meniscus tears need surgery, so I don't generally jump to an MRI just yet, unless it's a more dramatic, dramatic presentation. But oftentimes we'll start with maybe a cortisone injection for pain, some physical therapy, and then we see what happens. And a lot of times, even if there is a tear, the pain will go away. Now, if you try these things and the pain does not go away, those patients typically need surgery to fix them. And results are affected significantly by the amount of arthritis that's present. You probably all have had either friends or loved ones that have had meniscus tears, and you've heard different stories on how their recovery was. And that's usually affected by the amount of arthritis. So patients that have minimal arthritis can expect faster recovery, predictably good results. Those with more arthritis, slower recovery, mixed results. And if you have too much arthritis, meniscus surgery usually is not appropriate. All right. Now, so meniscus surgery, what's involved? So there are different types of surgery depending on what the tear is like. So a meniscectomy, that's trimming out the piece of meniscus. That's the more common procedure that I would say we perform, or meniscus repair. Some tears, especially if they tear all the way on the outside part of the meniscus, there's a better blood supply there, and those you can repair. But there are different factors. So younger patients have a higher chance that they're going to heal their meniscus tear, and those can be stitched back together. Also, younger patients need their meniscus more than patients as they get older because they have more time to wear out the cartilage. The location of the tear, so again, tears on the outside part of the meniscus have a good blood supply. Those can heal if you repair them. And also acute versus chronic tears that have been there a long time, more degenerative in nature. Those aren't ones you necessarily repair, more so trim them out. And then in terms of repairing them, there are a lot of different ways we can do it, a lot of techniques that we use. Most commonly, they can be fixed arthroscopically through a few little incisions around the knee. There are what we call all-inside techniques, outside in, inside out, and it's important that your surgeon understand these different repair techniques to get the meniscus repaired properly. There's another type of tear that patients may get called a root tear of the meniscus. I'll go to the next slide to talk a little bit more about that. But the root of the meniscus, so the menisci, as we showed in the picture, these C-shaped shock absorbers, and it tears back at the root attachment here. The meniscus can kind of be pushed out of the joint. And when that happens, that's a problem because it no longer is protecting the cartilage, and patients can develop arthritis pretty rapidly. So those are significant tears, and the right thing to do in a patient that doesn't have that much arthritis, the right thing to do is to fix them. Unfortunately, the recovery for that is not easy. You're on crutches for 6 weeks. With putting really little, if any, no weight down for the first 4 weeks, followed by partial weight for the next 2 weeks. We limit motion for 90 degrees for the first month or so. So it's not an easy recovery, but it is the right thing to do to protect the cartilage.
All right. Thank you, Dr. Benke. So I'm going to move into, some of the most common things that I see in the office, and that's really what falls under the category of cartilage disease. So you've probably all heard of cartilage before. Cartilage is the soft, spongy surface that sits on top of our bones, and this is what allows smooth motion of our joints. So all of your joints throughout the body have cartilage, but it's when that cartilage starts to break down that we develop problems. So cartilage can be injured in a trauma, like an acute injury, or it can slowly wear out over time. This can be a factor of genetics or weight, weight management, age. A few different factors can contribute to that. Cartilage is notoriously poor blood supply, so it does not regrow on its own. There are certain surgical techniques that can restore cartilage, but it has to be like a contained, isolated area rather than diffuse cartilage loss. Once the cartilage loss is diffuse, or if it's in multiple areas, that's when we start to call it arthritis. So knee osteoarthritis is an extremely common condition in the United States. There are some estimates that over 20% of adults who are over the age of 45 have symptomatic knee arthritis. The amount that have asymptomatic arthritis is probably even higher than that. Common symptoms of arthritis include pain, stiffness, swelling, locking, instability, all extremely common. I would say for me, the two most common things I see are pain and stiffness. This can develop slowly over time, or it can flare up extremely quickly. So sometimes the knee may stay asymptomatic for many years, even though it's progressing. I'll have patients who have bone-on-bone arthritis. They come to see me with pain, and I tell them this is arthritis. They say, "How's that possible? I've never had pain before." But sometimes it can just hit really quickly, and once that cat is out of the bag, it can get very hard to kind of settle down once it started to flare up. So what are some treatments for knee arthritis? I kind of categorize 3 boxes of treatment, depending on how invasive it is. The first line treatment is physical therapy, anti-inflammatory medication, and activity modification. So these minimally invasive treatments can be very, very helpful. I think physical therapy is beneficial to strengthen the muscles surrounding the knee, transferring the load from the joint surface to the muscles. That can provide a lot of relief. The next step up from that is doing injections. So injections can be very helpful to relieve symptoms, but they cannot cure the arthritis or regrow cartilage. So when these more conservative treatments no longer work, that's when I have the discussion about knee replacement. So knee replacement is the most reliable long-term management. Modern implants can typically last for 30 years these days. And now many knee replacements are being done outpatient in certain candidates. Recovery varies from person to person, but it typically takes 5 to 6 months to get back to doing your activities. So I want to talk about knee injections. These are really the workhorse of non-operative management for knee pain. This can be done for arthritis, for meniscus issues, cartilage disease. Many knee problems can be treated with injections. So there's 3 main kinds of injections that we use, and I'll go over some of the pros and cons of each. So cortisone injections, also known as steroid, this is probably the most common thing that is used. Steroid injections provide a rapid relief via an anti-inflammatory effect. So this will typically take effect within several days, and the effects will typically last somewhere between weeks and months. So more on the short-term side in terms of relief. Now, one of the downsides of cortisone shots is that there can be some toxicity to the healthy cartilage in the knee, particularly if you overuse this. So certainly 3 months is the minimum to repeat any sort of cortisone injection. But in general, I always say less is more. If we can keep these sort of cortisone shots to a minimum or space them out further, I always say that's better for the long-term health of the knee. Now, there are another group of injections called gel injections. These contain something called hyaluronic acid in them. So hyaluronic acid is a building block of collagen in the body. So you find hyaluronic acid in the skin, in the hair, and it's also in the cartilage of the knee and the joint fluid. So this functions as a natural material that's for supplementing the knee with, and it provides lubrication for arthritic surfaces. So when you're losing that cartilage and you have these potholes in the thinning, this can basically smooth out that surface. So this can take a bit longer to kick in, sometimes 3 to 4 weeks after the injections. However, it does last for much longer, typically somewhere between 6 months to a year of relief from gel injections. This can be either done in one shot, or we spread it out in a series of 3 injections to slowly build the gel up into the knee. Another good thing about the gel shots, it does not have any of the negative side effects of cortisone in terms of the health of the cartilage. So since this is a natural supplement, it's typically very well tolerated. Side effects are uncommon for this. The final injection that we use, and this is becoming much, much more popular over the past 10 to 15 years, is PRP, which is also known as platelet-rich plasma. So this is a biologic injection where we use concentrated platelets and growth factors from your own blood to provide a natural anti-inflammatory effect. So This is a situation where you come in the office, we draw your blood out, we spin it down in a centrifuge, and we take the tiny little part that has all the good stuff in it for healing, and that gets injected into the knee. This, similar to gel, does not have any of the negative effects of cortisone on the knee health. So there's no toxicity to the joint. It's your own cells. It can last for a very long time. So many studies report many months or even years of relief after getting PRP injections. Similar to gel, this can either be done with one shot or it can be a series of injections. And sometimes it's even combined with a gel shot where it can have a synergistic effect to provide relief. The downside of PRP, the catch, is that it's not covered by insurance. So depending on the patient and what sort of treatments they've tried before, some people are much more open to trying something like PRP. Other people would like to try other options first. In my practice, I've had some very good success with PRP. Dr. Benke, what's been your experience the past few years with doing these kind of injections?
Yeah, so I'll echo everything you said. I agree with everything you said about all these injections. Cortisone is great when you're in a lot of pain. It works quickly, sometimes even faster than a day. I had a patient today who said he felt better walking out of the office. I agree. Too much of it's probably not good for the joint. So I also try to limit it not more than every 3 months or so. The gel shots are great. They've been around for a long time. They first started use in the 1950s in racehorses, actually. And then shortly after that, they started using them for knee arthritis. And I'm a big proponent of the gel shots. I tell my patients, I think we should put it in the water. I think it's healthy for the and then PRP, totally agree. It's been gaining popularity. There's been a lot of recent studies comparing it to the gel shots. And some of the studies say they're the same. Some studies say it's actually a little bit better than the gel, but the downside is not covered by insurance. I think one day it will be covered by insurance because studies are showing that it's valuable, but not yet. And I think it works in conjunction with the gel shots. I actually have had a couple knee surgeries myself. I have some arthritis. I've done the gel shots for probably the last 4 or 5 years. And then over the last year or two, I've added PRP injection. And I think it gets me more life out of the gel shot. So I'm a proponent of it.
I love that firsthand account of the gel experience. Okay, well, we do want to leave time for lots of questions, so let's move on to some questions. Some questions were already pre-submitted, but please use the Q&A feature. Submit a question if you have now, and we'll try and get through as many as we can. Let's see what we have. All right, so Dr. Benke, I'm gonna throw the first question to you.
Okay.
When should someone consider getting imaging, like an X-ray or MRI, or seeing a specialist when they have knee pain?
Sure. So whenever you have an acute injury, that needs imaging. So twisting injury, contact injury, whether it's sporting or whether you just trip down the stairs, especially if you have swelling or some trouble bearing weight, I wouldn't neglect that. I would go to either an urgent care, an ER if you really have a hard time putting weight down on it. And then an X-ray typically will be done there. One thing to know, I see a lot of patients in the office that are upset with the ER that they didn't have an MRI done. The ER is not going to do an MRI for you while you're there. It's not because it's not emergent, but you'll then be referred to an orthopedist, a specialist, and MRI is warranted in a acute type injury. Now, pain that's been around more chronically, like for instance, a runner's knee type pain or some arthritis type pain, doesn't typically need an MRI just yet because the treatment, it's not really going to change treatment. I would get an MRI when it's going to change what we do. And if it's arthritis or even a meniscus tear, as I explained, they don't always need surgery. I would try an injection first, maybe some rehab, and see how they do. Now, if you're not responding, you still have pain after a month or so, that's when an MRI is needed.
And, the second part of the question is like, when do you see a specialist for this? Do you feel that, primary care doctors are equipped to treat osteoarthritis, or would you recommend once you get that diagnosis, once you've had chronic knee pain, just go ahead and see a specialist and get some advice from them?
Yeah, I think honestly, just see the orthopedist because talk to primary care often. Almost always, they're not going to have X-ray in their office, so you'll get sent out for an X-ray, which more often than not gets lost and then has to get repeated anyways. A lot of times, and this happened to me today, the primary care doc just ordered an MRI without any other workup. It got denied by insurance. So it's a
Hmm.
lot easier for us to get these MRIs approved when they're needed. We get X-ray in the office. So it's probably smarter to just see an orthopedist when you're having pain.
Yeah, I agree. I mean, I tell patients all the time, even if the pain is not severe or debilitating, it never hurts just to come in and have a chat about, what you're dealing with. Do we need to do anything? Can we just watch it right now? And the other thing to keep in mind, there's multiple kinds of specialists to see who treat knee arthritis. So, there are physiatrists who are like rehab physicians, there's pain management doctors. And then even within orthopedics, there's general orthopedics, there's knee replacement surgeons. And then there's surgeons like me and Dr. Benke, we are sports medicine surgeons. So we treat osteoarthritis with cartilage restoration. We treat meniscus issues, but osteoarthritis is definitely right up our alley. So I'm going to move to our next question here. What exercises are best for strengthening while also protecting the knees for people with arthritis or past injuries? This is a super common question that I get. Once someone's been diagnosed with arthritis, they ask, okay, like what can I do in the gym? What should I avoid? What activities? Couple things that I tell people, if you have osteoarthritis, particularly if it's, on the more advanced side, I recommend doing low impact exercise, high impact exercise. So a lot of long distance running on asphalt, concrete, um, jumping exercises, things like that, that can wear out the cartilage quicker. That can exacerbate your pain. So, as much as runners never like to hear this, I say you may want to cross train with low impact. So, work in some stationary bikes, some rowing, elliptical, swimming, things where you can get cardio without doing as much pounding on the knee. So, I think that's super important. Some things that can really stress the knee in terms of in the gym, uh, deep squats with weights, lunges, anything where the knee is having deep flexion and you're putting weight through that, that can be an aggravating factor. So, I often say, you may want to modify how much weight you're doing or go split squats or kind of modify a little bit so you're putting less stress through that kneecap. Anything in particular you would add to that, Dr. Benke, or those similar recommendations that you
No,
make?
I think you hit the nail on the head. I think low impact is better than the pounding on the joints, and it just going to flare up the knee. It's going to swell. But one other important thing is arthritis does like to be in motion. Arthritis does not like to be stationary. So if any of you have arthritis, you probably find that if you're sitting on the couch for a long period of time, then you go to get up, the knee is stiff and achy for the first few steps. We call that startup pain. So arthritis definitely likes to be in motion. But if you do too much, then it's going to flare up. So you got to kind of find that line of staying moving, staying active without overdoing it.
Totally. That is the toughest part. It's like where do you tiptoe that line? And honestly, that's where I think physical therapy can really come into play. Sometimes it's hard to know like what are the good exercises, how hard do I push it? So even if you're not going to do physical therapy for months and months, sometimes just going for a few sessions, having someone show you the exercises, the technique, I think that can go a long way. Okay, let's see what our next question is. So, Dr. Benke, what are the latest advances in treatments for knee pain, including regenerative medicine? So we already talked about PRP. What about stem cells? Any thoughts on that?
Yes, I mean I think the science is getting there. I think we use or I use when I do more so when I do cartilage restoration procedures than so much for knee pain in the office. We'll take bone marrow aspirate. So while patients are asleep, we'll aspirate bone marrow, typically from the pelvis is where I'll take it from. You can spin that down in a centrifuge, just like we do for the PRP, and get something called BMAC. So bone marrow aspirate concentrate is probably even more powerful than PRP for knee arthritis, but also for cartilage restoration techniques. And these things are always evolving with different places where you can get stem cells from. So better injections are coming. I don't think it's there yet, especially with insurance. That's lagging way behind. Things like BMA, bone marrow aspirate concentrate injections, then now you're talking more like $3,000-4,000 for an injection. And is that worth it? That I don't, probably not. but it's stuff like this is coming. Orthopedic biologics is one of the most exciting fields within orthopedics, and things are getting better, and it's exciting.
Yeah, I totally agree. I mean, I think this is a an exciting frontier for knee arthritis. I try to stay grounded in the science. There are a lot of stem cell options. I've seen a lot of papers that compare stem cells to PRP, and I don't see a huge difference in outcomes. So when I hear PRP, which is less expensive than stem cells, less invasive, is having similar outcomes to stem cells. It's hard for me to recommend spending 5 times the amount of money on that when there's not really great hardcore evidence that it's much better. There's definitely a misleading notion that stem cells are going to regrow cartilage, and that really does not happen. So the cartilage doesn't get restored from stem cells. What it can do is provide that natural anti-inflammatory effect. So that is similar to what the PRP is trying to accomplish. Other cutting edge things, we didn't really get into this too much in the talk, but the surgical techniques that are used to restore cartilage. So this is not necessarily for osteoarthritis, but for certain people that have more isolated cartilage defects, there are surgical techniques that myself and Dr. Benke are using now, where you can take grafts of cartilage from cadavers and try and implant them into the knee to get new cartilage. There's certain implants. There's a new implant that's made almost of like a coral reef substance that can try and regrow cartilage. So this is where I've seen a lot of really exciting developments is trying to regrow your own cartilage with certain surgical techniques. But again, it's got to be the right candidate and the right person. But that's another really exciting area that I've been involved in. Okay, what's the next question here? How do other factors like age, activity level, hip or ankle issues, overall health affect knee pain and treatment choices? Well, this is a great question. I mean, I try to treat every patient holistically, and see what else is affecting it. I mean, age, that's an obvious one. The older you are, the more your cartilage is going to wear out. That's just something that is a natural progression throughout life. Weight is a huge issue that I see. The more weight you have on your body, every pound that you lose, your knee feels that 5 times. So even low level weight loss, your knees will thank you for that. So I definitely think that is a major contributor to knee pain and knee arthritis in general. Hip and ankle issues, even spine issues, everything is connected in a kinetic chain, throughout the whole extremity. So I see it very commonly. Someone will sprain their ankle and then their knee arthritis flares up because they're not walking normally. So that can definitely be a big factor. Dr. Benke, anything you see in particular in terms of overall general health or recurring themes that can lead to knee pain?
No, I think you sort of covered it, but I totally agree. Hip, ankle issues, throw off how you walk, and then can flare problems in the knee. Especially, I see a lot with hip issues contributing to knee pain, knee problems. So it's an important part of rehab. Probably one of the bigger part of rehabbing after an ACL or rehabbing a runner's knee is actually focusing on the hips, I would say.
Dr. Benke, what do you say to patients, and I hear this all the time where, I tell them, a little bit of weight loss would go a long way. And then they say, well, I can't work out because my knees hurt too much. So what do you do in those situations when you're that conundrum?
Yeah, exactly. I mean, it's tough. I always will bring up weight loss, and I always will say, it's easy for me to say, it's hard for you to do. But the one point you said, and I remember learning in med school that every 1 pound you lose is you feel 6 times. So
Oh, okay, an extra pound, an extra one there.
But yeah. So even a couple pounds will help. But yes, it's hard to do. So that's where the lower impact stuff comes in. Cycling, swimming are a lot easier on the knee, less painful. Also, these days, the different injectables for weight loss have been very powerful in managing not only weight, but people's diabetes, A1C, things like that. So there are options out there. In extreme cases, weight loss surgery also, and your it'll go a long way in terms of your knee arthritis.
Totally agree. Low impact exercise, you can get a great cardio workout with a stationary bike, and typically it's not as hard on your knees. Something else to keep in mind, for our joint replacement partners, they often want a BMI under 40 for any sort of knee replacement. So that's another thing we run into where people say, the I can't get a knee replacement because my weight is too much, and then we kind of fall into this cycle of just trying to manage chronic pain. All right, let's. I think we have time maybe for one or two more. So let's see. So we have a question here about bracing. Dr. Benke, what are your thoughts on knee braces for arthritis?
Um, I, it's not for everybody. I think it's one more element to try because, as you mentioned, arthritis is a chronic condition. We can't remove arthritis. You can't cure arthritis. So there are lots of different little things to try: physical therapy, various injections, weight loss, and bracing is one of them. So a little bit of support to the knee can help. One brace that I think probably is pretty effective is called an unloader brace. So sometimes a patient will have arthritis in only one part of the knee, either the inside or the outside. And they make braces that can dial some pressure on the opposite side of the knee to sort of open up the compartment of the knee that has no cartilage. And that can be pretty effective also. And a lot of times insurance will cover a big part of those braces. So that's probably the brace that makes the most sense biomechanically, but also a knee sleeve or a more simple knee brace, just some compression can give you some relief for sure.
Yeah, I mean the unloader brace can definitely work in some people. It is a big brace. It can be a little bit bulky. I got to be honest. My first recommendation is usually just to go with a knee sleeve. A knee sleeve, it can help with some swelling. It just offers a little bit more support, and a lot of times you don't have to rely on the brace. Sometimes you get so used to like these unloader braces and your muscles, and I want the patient's own muscles to be doing the work in terms of supporting the knee. So I definitely think braces have a role, but not usually like a first line management to put someone in an unloader for me. Um, okay, let's do one more question. Okay, let's see what we got here. What strategies are most effective for weather-related stiffness? I say move to Florida. Um, uh, okay, so Dr. Benke, let's say you got someone who comes in acute exacerbation, swelling, difficulty bearing weight. X-rays just show they have the same knee arthritis, but now it's flared up. What's your go-to recommendation in a situation like that?
So yeah, someone had a hard time getting around, knee is swollen. I would drain the knee right there in the office and give them a cortisone injection. And they're some of your happiest patients. They will thank you so much. But then as the cortisone wears off, because it will be temporary, you get more into the gel shot. So usually, I mean, this is an extremely common scenario you just described. I will drain the knee, give them cortisone, and see them back in a couple of weeks, and talk about gel shots if they're interested. Um, for that
I
type.
totally, I totally agree. I mean, I think me and you are the same. We probably see this classic story all the time. If there is a lot of fluid, try and get the fluid off, calm it down with a cortisone. Gel does not work great for flare up. So that's why I try and tell patients, like when you're having a lot of pain and swelling, that's not the time that you want to put gel into the knee. So first, try and get the inflammation settled, get the patient more comfortable. And then for more long-term management, that's where gel comes into play. The only thing I would add to that is physical therapy can also be useful to get people back on their feet. Okay, I think that's all the time we have for questions. Okay, we're going to do a poll. Let's do another poll. Let's answer the question. So, how would you describe how you are feeling when it comes to knee concerns and existing treatment options with Summit Health? Hopeful, informed, wanting to learn more, or I'm not really sure. And we'll give a minute for some answers. All right. So we have 21% for hopeful, 51% for informed, 19% for wanting to learn more, and 9% are not quite sure. All right, well, Dr. Benke, I think this is great. This is what we hope to accomplish. The majority of our audience is feeling informed, so that's great. If you do want to know more, obviously there's plenty of resources online, or you can always make an appointment with one of our Summit Health physicians. So that's going to be it for tonight. We want to thank everyone for attending. Please remember to take the post-webinar survey at the conclusion of the event. Let us know how we did. We also want to let you know that if you want to revisit our conversation or share it with a loved one or a friend, we're going to be sharing a recording of this webinar in the coming days in case you missed anything or just want to go through it again. So Dr. Benke, thanks for joining me. And again, thanks for the audience. And I hope everyone has a great night. Thanks again.
Thank you, everybody. This was fun. Take care. Have a good evening.